This is my fun team, Fawzan and Jackie. Thank you. I had the problem. I had to change my topic a little bit after the lecture of Fawzan because he gave all the examples that I wanted to give you, talking about precision in genetic counseling. So excuse me and don't excuse my voice. My voice is okay. Excuse my bad English and the fact that I'm not as fluent as Fawzan to give some lectures. How do I skip? No, oops. I switch off. Do you know how does it work? Oh, yes. Okay, thank you. So you have the definition. I think Lutfi gave you the definition of what is precision medicine. And there is something, a new probably topic we have to talk about is precision in genetic counseling. And I'm going to try to show you how much important it is and give you some example. You know, I won't go through this. I think that we talked already about it, how we have to clean all those data that we are using. And I think that the labs, when they are giving us some results about whole exome sequencing or whole genome sequencing, I think they want to give us a result because they are very happy to put a diagnosis or to put a mutation. And in fact, many of those mutations we have in the report that they are classified in class 3, class 4, class I don't know what. But unfortunately, the physician, when they have the results, they look at the results and they see a mutation, and for them, this is the results of the mutation. And in most of the time, the mutations are not really the origin of the disease that you are seeing or the patient was referred for. So it's very important to clean it. And just to give you an idea, in the Lancet Oncology, recently, a couple of weeks before, a new publication in this journal talking about BRCA1 test done on young onset breast cancer patients, and they show that even if you do BRCA1, BRCA2 on young patients, and in comparison with the patients that do not present BRCA1, BRCA2 mutation, in fact, the evolution of the disease is absolutely the same. So do we need to go through it and to do for our precision in genetics, our individualized medicine, to do all those genetic tests, even though they are probably not very helpful in the follow-up of the patients. Anyway, I will talk about our own experience. You know, Lebanon, as you saw, it's a small country, but the consanguinity rate is 21%. So we have a big number of big families, and as Fawzan showed, families with very rare diseases. I'm going to give you some examples to show how it's difficult to give a genetic counseling and how much you have to be very, very careful. The first example, CAMOS Syndrome that we published, a new syndrome with cerebellar ataxia, intellectual disability, called before mental retardation, optic atrophy, and skin abnormalities. I published this family as a new syndrome. I was very happy. We did a genome-wide analysis on that time, and we found a mutation, a zinc finger mutation. The mutation was found in all the affected individuals. It was conserved. You know, we did all the data. We did the expression of the gene, et cetera, et cetera. So we were very happy, and we confirmed that this mutation was at the origin of the disease. And later on, I worked on another syndrome, the Galloway-Mowat syndrome, and we found also a gene involved in the Galloway-Mowat syndrome. And when you see the phenotype of the Galloway-Mowat syndrome, there is microcephaly, cerebellar atrophy, and intellectual disability with a nephrotic syndrome. So it was very close to the syndrome that we published at the CAMOS syndrome. So we went back through our origin analysis, and we found a mutation in the Galloway-Mowat syndrome, a homozygous mutation. And this mutation was typically involved in our syndrome, in the CAMOS syndrome. So we had to change completely our diagnosis. And we're very lucky because I didn't see the family anymore. So for the genetic counseling, they didn't come to see me because they wanted to get married and ask for a genetic counseling. Otherwise, I would have done the zinc finger gene analysis in this family and not the real gene, which is the gene WDR73. For the Galloway-Mowat syndrome. And after we republished this family, we found that in some of the Galloway-Mowat syndrome, there is no nephrotic affection. So we now can consider that probably those are two allelic, if you want, rare syndrome. Anyway, probably the ring finger is also playing a role in the penetrance of this disease or anything. Anyway, this is another family also that we published. Oops, go back. And this is a rare syndrome also, an ataxia type Norman. And when I published this huge family, as you can see here, there was an association of this cerebellar ataxia, non-progressive cerebellar ataxia in this case, but also a very short stature. So I said, this is very interesting. This is a new syndrome, close to the Norman syndrome, but probably it's something new. In fact, when we found the gene, we were very happy to find the gene, and we thought that it was related, the short stature was related to the same phenotype. It was all on the same phenotype. And when we did a whole exome sequencing on this family, I don't know why, probably to find something else, we found that there was another gene mutated in this family. One gene was at the origin of the short stature, and the other gene was at the origin of the cerebellar ataxia. Here also, be very careful, because when you see a family or any of those normal individuals getting married with a cousin, and if they want a genetic counseling or a prenatal diagnosis, if you give them only a mutation of the cerebellar ataxia, you're not giving them also the mutation of the short stature, so we have to be very careful. Yes, you won't have a cerebellar ataxia, but after they come to see you in the clinic after a few years, probably telling you, but you know that there is a short stature, and you didn't tell us that there will be also a short stature. This is another family. Didn't publish it, but probably without a whole exome sequencing, or without being, very much involved in this family, I would have published it as a new syndrome with achromatopsia and cardiomyopathy, hypertrophic cardiomyopathy. Because when you see such a family, we published a lot of cases like this when you have in the same family an association of features. And probably I would have published this family as putting novel report or new syndrome associating achromatopsia with cardiomyopathy, hypertrophic cardiomyopathy. Doing a whole exome analysis, we found that there was two genes affecting the same family. The family is consanguineous, and unfortunately, the two SIBs here had the two diseases and were presenting two different syndromes on the same individual. So be very careful also when you have very strange associations, very rarely published association. Be aware that sometimes you can have many syndromes involved in the same gene. And this is what we did. We participated in, we published this new syndrome with the marfanoid habitus, long stature, inguinal hernia, advanced bone age, and very distinctive facial features. And when we published this family, we thought also it was a single gene. And you see here the features. And Sibel Mehawish did a very good genome-wide analysis and then whole exome sequencing. And she was able to find a gene, the metyl-21D gene. It's a metyl transferase gene, and we're very happy because we linked the genes, showing that some other, in the same pathway, other genes are involved in Sotos syndrome or Werver syndrome that gives also an overgrowth syndrome. So we said that we have a tall stature, and we have here genes involved in the same pathway with Sotos syndrome and Werver syndrome, so we were very happy, very happy. And when we came back to the analysis of the whole exome sequencing, because we worked this with Valérie Delague from Marseille, and I think she's a little bit too much obsessive, and every time she found a gene, she wants to do everything to find another gene involved and say, you see, we cannot publish this gene because there is another one. So you know, to publish one family, probably we spent 5 years, working on it. At the end, we don't publish it because somebody else published it. Anyway, so we went through it another time, said, I want to do it, I want to reanalyze the whole exome another time, and she found another gene involved in it. And this other gene also, when you see in knockout mice, it's involved in early aging, herniation, and in the problem of elastic fibers. and at the end we put the clinical, very close to the clinical presentation of our patients. And probably here also we have two genes involved in the same family. One of the genes involved in the tall stature, and the other genes is involved probably in the early aging facial features that we can see in this family, etc., etc. So still, we did not publish it because even Sibel want to have some confirmation about the effects of the two genes, and Valerie, no, I'm not sure, probably there is a third one, I'm not sure about it. So I said, okay, don't worry. So we will keep it. And just for the fun of it, I saw this family also, a young man with a very, very bizarre phenotype. I was so excited to this family. You know, as a clinical geneticist, when we see something bizarre, we're very excited. This is why you listen to the topic of Fawzan, it was very excited, very happy. So it's amazing how the endorphins can go up when you found something. So I was very happy, not for him, but for me, to see this affected the child. He refused that I show you the photos. Anyway, you can see that when we did an exome, it was so strange that, in fact, we found 3 mutations in 3 different genes. So unfortunately, the parents are consanguineous. They are from Armenia. So the first time, you know, in Lebanon, Armenian usually does not get married between each other. So it was a very rare marriage between cousins for Armenian people. Anyway, they were so unlucky. There were 3 genes. Parents were heterozygous for 2 genes, the THOC6 and PTCH2. And also there was another, the mother was a carrier for the EDAR gene. So in the same individuals, we had 3 different genes. So there was a mixing of all those features in one individual. So be very careful here also. But this is the easy part of it. And the difficult part of it, and here we have to be very, very attentive and very careful. This is a very big family. I don't know if I presented it here once, with the very classical syndrome of Bardet-Biedl. Clinical geneticists can put the diagnosis very directly. You have an overweight, polydactyly, intellectual disability, deficiency, and some vision problems. And so at the first, when I saw this family, we used to do, before, you know, because of the money problem, we used to pool all the DNA of the patients. So see, all the patients had the same genes, so we'll do one pool for all the affected, one pool for the real carrier, and one pool for the unknown carrier, if not carrier. So we put all the affected individuals in the same pool, and we tried to find a specific region in the genome to find the gene. And when I saw this family 15 years before, I was sure that I was going to find the gene in few months. Nothing. I sent it to the United States. Nothing. I sent the DNA to I don't know where. Nothing. So we did it for probably 10 years. And at the end, after 10 years, a friend of mine came from Strasbourg, from Jean-Louis Mondel group. And she told me, listen, I want to do and to work on Bardet-Biedl. Said, don't be crazy. I tried to find a gene in this big family and said, don't worry, I will do it. We will do a new technique, the whole exome sequencing. So she did the whole exome sequencing, and she found nothing. So because there was money, she did a whole exome sequencing, not on the pooling of the DNA, but on each individual. In fact, she was able to find that in this family, there was 3 groups in SIPs, what are they? A, B, C here. We found a novel gene, BBS10, which was found later on to be the most frequent gene involved in Bardet-Biedl syndrome. So I don't know why we found it 7 years after the first gene. So the most frequent one, BBS10. And we found in the family E, another gene in family D is here, family G, another gene involved in Bardet-Biedl, BBS2 in Bardet-Biedl syndrome, the gene number 2. So you see, in the same family, you have 2 different genes involved for the same very, very, very rare disease. So this is very important, because if you see this individual D1, and he asks you for a genetic counseling, D1, and you said, okay, I'm going to give you a genetic counseling, I will test the gene of BBS10, because this is the one involved. And you give an answer, lucky you are not carrier of the BBS10 gene, so don't worry, no risk for you to have at least a Bardet-Biedl syndrome. And then the first baby is okay, I'm very happy, you are a very clever doctor, and then the second one is affected. You have a big problem here. And the family will come tell you, but you told me that there is no risk for Bardet-Biedl syndrome. I usually refer to God, say, you know, I don't know, subhanallah ta'ala. You know, it's quite difficult. And this is not very, very difficult. I would say it's still easy. This is not the good pedigree. I had to change the pedigree, change my topic because of Fawzan. But I copy-paste another pedigree. Forget the pedigree. What is important, and this is my last slide. I still have 30 seconds. I saw this family with metachromatic leukodystrophy. We sequence the gene in the first part of the family. This is not the good pedigree anyway. It's just for the idea. And we found the mutation. We're very happy to find the mutation. And then came a cousin of the family. So I tested number 4 here, 4, and she was carrier for the mutation. So I tested number 4, 5, and number 4, 5 was not carrier of the mutation. And they had the baby with the leukodystrophy. So it was very, bizarre. And then I sequenced the whole gene, the ARSA gene, and we have found another mutation that also was segregating in the family. So we have one mutation in the ARSA gene, and unfortunately, one of those, 4 or 5, was a carrier for another mutation in the same gene. So they had also a leukodystrophy. The child was affected with a metachromatic leukodystrophy, but it was completely different from the family that we investigated at the beginning. And I'm sure that when you are doing a whole exome sequencing, not probably for rare diseases, but for the frequent diseases, I'm sure that when we do a panel of gene, I'm sure that in each of your family, probably you are finding a gene in a mutation in one specific gene, and other mutation also in other genes involved in the same syndrome. For example, I see this very often in deafness. In retinitis pigmentosa, when we do a panel, we have a mutation in one gene and other mutations in different genes, and we don't know how they interact between each other. So be very careful when you are doing and when you are giving your genetic counseling to families when they are consanguineous, because you have a lot of mutations that can unfortunately come together in one affected individual. I think it's finished. Yes, so sorry if I did some mistakes. I like very much what said Jean-Jacques Rousseau. I have support certain what I only knew to be probably certain, and if I did something wrong, so it was not my fault. I didn't want to give a wrong diagnosis, but sometimes we did many things wrong. This is what shows us Fawzan and what I tried to show you now. Thank you.